and thank you for joining us for another edition of Matters of the Heart, a program brought to you by Haverhill Community Television as well as Pentucket Medical Cardiology. My name is Dr. Srivistava, and I'm a cardiologist here in Haverhill. I'm joined today by one of my colleagues and associates, Dr. Drs Bilazarian, and we're here today to talk about something that I think is very exciting, a new therapy that's come to the horizon here for a condition that is a very important condition called atrial fibrillation. We've talked about atrial fibrillation several times on this program in the past, mainly because it is a very prevalent, common problem. 6-7 million Americans have it. And one of the mainstays of therapy involves blood thinning. And so there's lots of new and exciting developments around that arm of therapy. And so I'd like to hand it over to Dr. Bilazarian and let him chat a little bit more about this.
Great. Well, I'd love to have your insights because you and I are both trying to reconcile and figure out, integrate this new therapy. We're just filming this a few days after the FDA has released the third drug that's approved for thinning the blood in atrial fibrillation, as you just said. And I think we've talked many times in this program about the longest one around, which was called Warfarin or Coumadin. That drug has been around since the 1960s, but until a year ago, that was the only drug we had. A year ago, a drug was released, and it's been out now for about a year. It's been advertised on TV. I think most people probably have seen advertisements on TV for a drug called Pradaxa. We're not talking about that one. We've covered that previously. That drug's been out for a year. We have some understanding about its pluses and minuses. But the FDA, within the last week, now in November of 2011, has approved the second new drug or the third drug for atrial fibrillation. And this drug is called Xarelto. It's pronounced with a Z sound, but it's spelled with Xarelto. So Xarelto, or the generic name Rivaroxaban, it's a mouthful, but is the third drug for blood thinning, the second new drug, and we're trying to sort out what to do about it.
Great. So maybe tell us a little bit about how we got here, what led to this drug being approved, the research studies that support its use, or what the data is.
Sure.
So maybe you can tell us a little bit about that.
Well, about a month ago, the study was published in the New England Journal called the Rocket AF study. These studies all have very fancy, cute names to make people think about them. But the Rocket AF study was a study of this drug, Rivaroxaban, in atrial fibrillation. And what they did is they did what these studies always did. They put half of the patients on the standard treatment, which is the Warfarin or the Coumadin, and half of the patients got put on this new drug, Rivaroxaban. And they said, how do people do? And what are the two things we want to know when someone's on a blood thinner? Did it work? Did it prevent clots from causing strokes or clots from going to other parts of the body? That's called cerebrovascular accident or systemic embolism. So did it work? And number two, did it cause problems with bleeding? That's really what we want to know. So how did this drug, this new drug that's just been approved, compare to Warfarin? Now, we don't have a comparison to the other new drug, and that's what we're always struggling with, you and I, as clinicians, is where does it go? Because we only have a comparison to the older drug. Just for a moment, I'll tell everyone that the older drug called Pradaxa is better than Coumadin in that first thing, in preventing strokes, but it's equal to Warfarin in the bleeding risk. So it's better in efficacy, we would say. It's more effective, but it's equal in safety. So that's what we had before we have this data, and now we have this data for this drug. So we'll talk a little bit about that.
So tell me a little more about the study. So how big of a study was this? Is it all over the world, just the U.S.? Just I want to get a feel for that.
Yes, well, it's a great question that you asked because we also try to look at this, you and I, to say, is this study, even though the FDA said it's good, I still want to make a decision for my own patients. So this was a pretty enormous study, 14,000 patients, 7,000 got the new drug and 7,000 got the Coumadin. And the reason why that's really important is we like big trials because the bigger the trial, the more confident we can be that the data is real. If you do a small study with a couple people, it could go either way. But when you have a big study, it costs a lot of money, so the companies don't like to do them, but the FDA is requiring these companies to do big studies, which makes us very confident because a bigger study, the more likely we'll find potential problems. We'll have different groups. There'll be men and women. There'll be different racial groups. There'll be different ages. There'll be different groups of people who have different other medical problems. So we'll be able to pick up different problems that might occur. There'll be patients who are on different drugs, so we can find out about drug interactions. So to answer your question, it was a big study. It was done around the world, but a lot of patients were done in the U.S. Another important thing that we'd like to know is, was the study done mostly outside the U.S., or were a lot of patients done inside the U.S.? And there were a lot of patients done inside the U.S. So the study was well conducted, it was big, and it was done around the world, but a lot in the U.S.
Very good. So what did we find? So 7,000 get the new drug, 7,000 get the old drug, and how long were they followed, and et cetera, and what were the findings?
Well, let's just talk a little bit about who was studied first. So let's talk about the base, what's called in these studies the baseline demographics. So who was in the study and what was involved. So I want to just say that I told you that the more we do these studies, the bigger the studies, the more we're able to look at other groups, but 83% of the patients were Caucasian or white, so that means only 17% were not white. But when you have a 14,000 patient study, 17% of patients being non-white gives us a sense about a little bit of diversity to be comfortable. 19% of the patients were in North America. And one of the things about this study that I do want to emphasize is that it was a high-risk patient population. Now, the last study that was done of the Pradaxa, which we reviewed on this program, looked at patients who were a little bit lower risk. So this was a higher risk patient population. And the key thing that I would mention is that over half of the patients, 55% to be specific, of the patients that entered this trial had already had a stroke. So that's a very high risk. We say that there's 5 important risk factors for having a stroke if you have atrial fibrillation. And you and I go through those with our patients. You can take a moment and do that for us.
Sure. Someone's age, if they've had congestive heart failure, high blood pressure, diabetes, or a stroke or a TIA.
Right. So you just mentioned what we call the CHAD score. It has 5 letters, but we say there's 1 point for each of them except the stroke, which we say there's 2 points. So it's twice as important or twice as worrisome if you have a stroke. And 55% of the patients in this trial had already had a stroke. So it's a very high-risk patient population. So that's an important thing. But to get to the meat of it, as you said, the question is how did they do? And it did show that this drug, Rivaroxaban, did as well as the Warfarin. It looked like it at preventing a stroke. Thank you very much. Yeah. So it did as well as preventing a stroke as the Warfarin. Now, I mentioned to you earlier the Pradaxa looks like it did better. so I can't say compared to Pradaxa, but I can say that Pradaxa was compared to Coumadin, and it did better. And this was compared to Coumadin and did as well. Now, there's many differences because I already told you one difference is the different population. So what do we do? And, sometimes you'll talk to a doctor who works at an academic medical center, one of our premier medical centers in Boston, and they'll say, well, you can't make a comparison because there was no direct comparison between these 2 new drugs. But for us in practice, we have to make the comparison because we have to try to judge which is the better drug. So what are your thoughts so far about what I've shared with you?
I really don't know.
Well, we don't know, but how will you vote? Because you're going to write a prescription and you're going to vote for your patient.
Yeah. Well, before I answer the question, I want to hear more about the bad.
Okay.
So what about the bleeding risk and whatnot?
Sure. Well, so the bleeding risk looks like the bleeding risk in a couple of areas was better with this drug in 2 important areas. Bleeding that caused death and bleeding in the brain called intracranial hemorrhage were both better with this drug compared to the Warfarin.
And that was the case with Pradaxa as well.
Correct. But the overall bleeding rates were the same. So there was no difference in major bleeding or other kinds of bleeding, Warfarin. So we can't say it's better on bleeding. It is better on a couple of important bleeding types, but overall bleeding was equal. So to answer your question, it looks like it's equal on being equally effective, and it looks like it's about equal on bleeding. Yeah. Now tell me.
Yeah, no, it's complicated. I think that the fact that this was a higher risk population makes you think favorably upon this drug, that it was just as good in a very high risk population. You can feel better about using that drug then. But no, of course, you'd love to see the head-to-head comparison, which I don't think we'll see anytime soon.
Okay, so this is fun, and I really, because you and I haven't talked about this,
yeah,
so this is an unrehearsed discussion, which is fun. So let me complicate it further. So one of the things that we want to know is, was the comparison a good comparison? And I told you at the beginning of this that Warfarin is the standard treatment. Mm-hmm. But of course, everyone who knows about Warfarin in our audience, Coumadin, knows that you have to have your Coumadin level checked all the time. And we know that the more you're in range, the better off you are. So if you're always out of range, your Warfarin really isn't good for you. Now, this trial had less people in range than the Pradaxa trial. 55% of the time of the patients in the trial that we're talking about today on Warfarin were in range. and the number was much higher in the Pradaxa trial. Does that change it? You said you thought it was favorable because it was higher-risk patients, but now the comparison was not as good a comparison. They didn't do as good a job with managing the Coumadin. How do you weigh on that?
It's hard to say. I mean, I think that's, and I don't know off the top of my head the statistics on what in real life patients on average are maintained in a therapeutic window with their Coumadin. I think it's lower than what's usually seen in trials.
That's true.
So, I don't feel like it's as much of an issue because I suspect in real life patients are less than either one of these trials for the most part. So, without having really dug through the study in nitty-gritty detail or read every editorial commentary that's out there about it, this is very exciting. This is a once-a-day drug too, correct?
This is a once-a-day drug, and we'll talk about that a little bit as well. So that may be a reason to choose it as well. So the overall other side effects, there wasn't really much difference in the adverse events between this drug and warfarin. Like, people didn't complain about side effects at all. So that's a good feature of this drug. So overall, I would say we've got to come to the conclusion of this. The conclusion of this study, when it was published in the New England Journal, and this was the study that led to the FDA approval, was that this drug was not inferior, sort of it's equal, to warfarin for the prevention of stroke. Rivaroxaban was superior to warfarin if patients took it. So it's one of those things about the studies is that if you took the drug, it was actually better than warfarin, but some people just stopped the drug, and yet those people have to be counted in what we call an intention to treat. So in a study, one of the things you and I have to interpret is once you're assigned to it, you're considered to be on that throughout the study. So if you look at that, they didn't really do as well. But if you actually took the drug, it was better than warfarin. I'm not sure how to interpret that. And then the safety issue was similar rates of bleeding, but less of that intracranial hemorrhage, which is a terrible thing when you bleed in your brain, because often that causes death. And then Rivaroxaban is now a proven alternative, was a conclusion of this study. So let's go forward now, and now we move forward because, as I mentioned, in the last week, the FDA has not only released a drug, but has released the prescribing information. So you and I, as doctors who write prescriptions, are expected to go through this and make sense of it and decide how to use it. So let's talk about it.
Before you do that, real quickly though, I just want to, on the FDA approval process, and I know there was some controversy and some leading groups out there who were advocating for this drug to not be approved. Maybe we can talk about that just for a minute or two about what the story is.
Yeah, I don't really know what to make of that. I mean, there is a group called Common Cause, and they're a group that is reportedly, their mission is for patient safety and public advocacy. I don't know if they have other agendas. I'm not saying anything plus or minus about that group, but they were very vocally saying that this should not be approved. And they use some of the things that I was, giving you a little bit of a needling about, is that maybe the drug shouldn't be released because the warfarin levels of effective warfarin use was a little lower than what we'd expect. We normally want to see it over 60, preferably closer to 65%. This was 55%. So if it wasn't a good comparison, well, maybe it's not fair. Now, the drug wasn't better. So if the drug's not better, does it really need to be approved? Because we have Pradaxa, which was shown to be better. So there was some reason to say that there wasn't a real feeling like you had to approve this drug. Before we had this drug, we were really clamoring for an alternative because some people can't take warfarin. There are issues with it. But now that we have an alternative, do we really need this alternative? So I think that was the focus of the criticism.
Sure. Okay. So now let's go forward here.
So let's go forward. And again, I'm enjoying talking to you about this because we get to talk a lot, but we haven't talked about this particular subject. And I guess I'm asking you to honestly share with me what your thoughts so far about this. And I am asking you a general question. Do you think that with your next patient, we're busy, and you're probably going to see a patient with atrial fibrillation tomorrow. We see one almost every day in the office, sometimes several. Should you think about these as one of three options? Or should we think about warfarin as the standard treatment and then consider these two new options? It sounds like a simple question, but I think it's really an important question.
It is an important question, and I don't have the right answer to it.
There isn't a right answer, so that's why I asked you, what are you going to do tomorrow?
And I don't know if I really think of, I don't know. I really don't know. I don't think of, I'd like to shift away from the mindset that warfarin is the default because these new therapies have the potential to be better. And one other issue, too, just more convenient for people, which is a tremendous thing. I mean, the Coumadin is not without its negatives as far as how often they have to come for blood tests. And
so they have to come at least monthly for blood tests,
often
more
but
than
then,
that.
Right, when then there's some, you go on an antibiotic or something and it interacts, and that's another issue. it interacts with so many medications and so many things that it would be fantastic to shift away from the thought that warfarin is the default and we're going to occasionally use some of these others. But again, like anything, it's brand new. So far, I got to say my experience with Pradaxa over the past year has been very good. I think for the most part, patients have tolerated it very well. They've been very happy. It's been liberating for some people as well, and so I'm excited about this third option. And I don't know how to view it. Do you view it as warfarin here? You know, are you deciding on warfarin or new therapies? And then you got to pick between the news. I don't know. I'm not sure yet. So.
Well, let's talk about some general info from the prescribing info. So this drug is in a class called factor 10A inhibitors. It blocks a certain part of the way our body makes clotting factors. It's indicated only for a particular kind of atrial fibrillation called non-valvular atrial fibrillation. And when I say a particular kind, it's the majority of atrial fibrillation is this type, that when people don't have a heart valve problem. It's should not be used in patients who have severe kidney dysfunction. We calculate a blood test called the creatinine clearance. It's a very simple calculation based on a blood test to figure out a patient's kidney function. And if a patient's kidney function is a little bit down, we use one dose, but if it's normal, we use the regular dose. So 20 milligrams if the creatinine clearance is over 50, and if it's 15 to 50, we use a lower dose of 15 milligrams. So that's something that's new for us. We haven't done that in the past for warfarin, but we are already doing that for the Pradaxa, so we are familiar with that. The package insert says that we have to periodically check patients' kidney function because, of course, if they start out with a normal kidney function, then over time their kidney function gets worse, we may have to adjust the dose. But you and I aren't given any guidance on what does that mean. Does that mean twice a year, once a year? We have to figure that out. And the last thing is, to speak to the issue you talked about the once a day, is that the drug does get better absorbed when you take it with food. So it is recommended that we take this drug at night with our supper once a day. So we're going to talk a little bit about that. So what's the similarities of this drug to that other new drug? You said you've used Pradaxa, you're comfortable with it, you've been pleased with it. So let's take a few minutes to compare similarities and differences between this drug and the other new drug. So number one, you already said no monitoring is necessary. Not only is there not monitoring necessary, there's not possible to monitor. Right. So that makes us a little bit nervous as doctors because one thing we like to do is sometimes check blood tests to see if a patient's taking it. Not that we don't believe every patient, but we like to make sure they're taking it. One of my patients today was taking the Pradaxa once a day instead of twice a day, even though I clearly told him that. I wrote it on the prescription, and I even called this patient's daughter on the telephone, and he was taking it once a day. But I couldn't have checked that to prove it, to see that he was on a low dose because I can't check it. So that's sort of a plus and a minus.
You can't do that with a lot of drugs. You know, we prescribe cholesterol medicines, other medicines.
Well, we can check cholesterol.
You can check cholesterol, but a lot of times people take their pills and it just doesn't lower it a lot.
Right.
But, or sometimes we have blood pressure pills that were given twice a day, so you have no way of knowing.
Sure.
So,
okay.
So I don't agree with that. So that one doesn't. That's not a negative.
Okay, so that's a similarity between the two new drugs. Another one is there's no way to use as an antidote. If someone is bleeding, they have a car accident, there's not an antidote. To some extent, we don't mind that. We have some ways to work around that. We can give a blood product called fresh frozen plasma. And because the drugs are short-acting, they wash out of our body pretty quickly. Another thing is that our body gets rid of them through the kidney, so we would have to measure the kidney function. Another one is they come on very quickly. So if a patient has a clot in their leg, for instance, called a DVT, you can give this drug, and in 2 hours, the blood thinner levels are up.
But you can't give this drug for that.
Well,
right?
This drug is approved for that.
Yep, right.
The other drug, Pradaxa, is not, but I'm only using as an example of very rapidly. So you don't have to use heparin like we do with warfarin, because warfarin or Coumadin takes 3 or 4 days to come up to speed. So I'm just saying it comes up to speed pretty quickly, and it goes off quickly. And stopping it is recommended 3 or 4 days before surgery, 3 to 5 days before surgery. So those are the similarities between the two drugs. Let's talk about some differences. It's a different kind of action on the clotting system. But one thing that's a little bit concerning is that in the package insert, there are two things that doctors call black box warnings. They're actually in a black box right at the top of the page, and it says two things that we have to worry about with this drug. And I'm going to ask you whether this is meaningful to you. One is that this drug, if you use this drug and then someone has surgery and gets like a spinal anesthesia or epidural anesthesia, they can get a bleeding around the spinal cord, spinal hematomas. And the second thing is that in the study that we talked about, when the drug was stopped, there was a higher rate of of strokes that occurred when people were switched from this drug to warfarin. So those are called black box warnings that doctors have to worry about. Let me just finish these differences, then I'll ask you again what your thoughts are about it. You mentioned already that the Pradaxa is twice a day, taken every 12 hours, morning and night. This drug is once a day, but has to be taken with an evening meal. I told you already that the Pradaxa is superior to warfarin. The Rivaroxaban was equal to warfarin. I didn't mention some other study differences. I'm not going to mention that, but I did mention that these patients had a higher score that said that they were higher risk in the new trial. The RELY study, or Pradaxa, the patient had a CHAD score using that 5-point score of 2. This one, patient had a score of 3.5, so much higher risk of stroke. I mentioned the difference in the time in the therapeutic range for warfarin was much better in the Pradaxa than in this one. They also recommend that we can start this drug when the patient's Coumadin or INR level is down to 3 with the new drug. We have to wait until it's down to 2 with the Pradaxa. And the final difference, as I mentioned, is that this drug, the new drug, is indicated for clots in the legs and atrial fibrillation, which is what we're talking about today. And the Pradaxa is only indicated right now for atrial fibrillation. So let me stop again and ask you, because I know that this is new to all of us.
Yeah, I mean,
and I've gone through this a couple times now by myself, and I know you've just seen this.
I've just skimmed things.
Okay,
I haven't
so
really
tell me
dug
what you
into
thought now
deep.
that I'm sort of bringing this up.
Yeah, no, it's interesting. The increased stroke post-drug cessation is an interesting thing.
Is it real, or is it just a function of the study?
Well, that's what I was wondering. Is it just because these are higher risk individuals, and that's all it is? And I don't know the answer to that. Intellectually, I guess I would think of it in that way. But I don't know for sure.
One thing that I ask, and I talked to some other physicians about this, and I've shared some of this with some other physicians, and I've asked, and I'm asking you, do you think that doctors should be worried from a malpractice risk? If there's something that says clearly that this is a warning, does it change the way that we should behave in the way we stop the drug or around the time of a spinal anesthetic?
Yeah. I don't know. I mean, I think I think it's all about communication with somebody and telling people this is what we've seen, here are choices, and we're their consultants, so to speak, and give them options and educate them. So, because there is no right or wrong answer.
Okay.
So I think you just give people the information and make the best decision you can.
Okay.
So I don't know what the right answer is. The spinal hematoma thing is an interesting thing. I don't know the details of what was found, or is it when people were still on it, or it was stopped for 3 to 5 days beforehand, or what was the story behind that? Do you know?
I don't know the details beyond what was in the package insert, but I suspect that like any issue, you stop a blood thinner and there's some bleeding risk, and maybe we need to learn to wait longer.
Right.
But even if we waited longer, that might be a risk for the other risk of the bridging thing, of being without the medicine and being at risk. So that's the concern I have about this drug, which has made me somewhat concerned. So let me skip to my view of the for and against on this, and I'll ask you again to weigh in and tell me where you think. So the for this new drug, we're talking again about this drug called Xarelto or Rivaroxaban. The reasons that I think would be for or a pro use of it is that it is convenient, no monitoring, that it's once daily, it's not inferior or less good than warfarin, and that it's superior with a very important thing, bleeding in the brain.
Yeah.
But against is that it's not more effective than warfarin. And I said it's for, but it's also against, because why should we use a new drug that we don't have as much experience with if it isn't better than the old standard?
Well, to counter that, though, I would say, if you ask any patient, they hate taking Coumadin. Okay. Right? I mean, is that your experience? Most people, yeah. And so
let me finish the against, then I want to hear what you have to say. Another against is it's not less bleeding, so it's not safer. So it's not more effective, it's not safer. So that's a reason. These are against, in my view, to take on a new drug. It costs $180 a month, another against in my mind. Similar, almost exactly the same cost as the Pradaxa, so it's not an advantage Pradaxa, but it is obviously much more expensive than warfarin, which is very inexpensive. And there does seem like there's more drug interactions compared to Pradaxa. The only drug that's listed for Pradaxa is a drug that we use for TB called rifampin, but there are a few other drugs that are listed in this, so a little bit more caution there. And then the last bit is this black box warning. So I just want to get your thoughts on, after the for and against, do you have anything that you think for and against, and have I swayed you either to say I'm going to be cautious with this, or I'm writing this prescription tomorrow?
I always tend to be a little cautious with something that's brand new anyways, but I guess I'm not as some of the against that you listed, such as being the same with bleeding risk to me is not an against. If anything, it's a neutral or another argument as to why you would still, because for me the convenience factor is such a major thing. If it were me having to take a blood thinner for atrial fibrillation, I would very strongly consider taking one of these new ones, if not for anything more than just the convenience and lack of need for monitoring and lack of interaction with every drug or food possible. And there's there's a proven efficacy there. So
You said you didn't want to really commit to it, but I'm hearing you say that you believe that we're really at a fork in the road.
Yes.
And it's warfarin versus the new drugs, and it seems like you're favoring new drugs, and it sounds like right now you're comfortable with Pradaxa having had a year's experience.
I've been pretty happy with it. There's certain patients obviously it doesn't work for. You went through the kidney patients and some elderly folks and things like that. But I do think this new. It seems to me that there's many more down the line here, similar. Right. That this is a true fork in the road with the treatment of atrial fibrillation. Right. And that I think if you go 5 years forward from now, I think there'll be far fewer patients on warfarin compared to these drugs.
Yes, and I think that what you said is really important, and we'll probably should finish up with that. But the next drug that we're going to get in the next year is better than warfarin in efficacy and safer with bleeding. Yeah. And I think for you and I, there's not going to be a struggle when that drug comes to the market unless there's something else unexpected. And we're going to carefully go through and assess it and look at it, and we'll present it to our audience. But I think we're going to not be struggling like we're struggling today.
Sure. Well, that was a great review of a new drug, and actually it was a review for me too, because this truly, as you said, has just come out recently, and so many of us have not had time to really dissect it, so thank you for that. It's an exciting time with new therapies, and I'm glad you reviewed it for us. So with that, we'll conclude. This was another edition of Matters of the Heart, brought to you by Haverhill Community Television and Pentucket Medical Cardiology. Thanks for joining us.